Hey everyone, this is Ahmed Farag. I'm one of the ESIR residents from the University of Kentucky, PGY5, and one of the co-chairs for the Communications Committee for the RFS. We help put on these webinars. Today we have a great webinar from the Interventional Pain Service Line ran by Chin Lee. So Chin, I'm going to let you introduce our speaker.
Yeah, can you hear me?
Yeah.
Okay. Yeah, thanks for everyone joining tonight. Well, my name is Shannon. I'm one of the residents at the University of Pennsylvania. I have the pleasure to introduce Dr. Stephen Hunt, who is a interventional radiologist at the University of Pennsylvania. He's also one of the co-directors of the Pan Image Guided Intervention Lab, or the PIG Lab. He's pretty well known in the field, and I heard he's a pretty good speaker, so I'll let him take over from this point on.
Thank you, and thank you all for tuning in, and to everyone who's on the delayed broadcast, thanks for watching. We're going to be talking today about really covering a broad overview of some interventional pain techniques, hopefully just whetting your appetite for lectures on the subject. So this covers a lot of ground here. Let me know when you can see my screen, folks. Are you able to see the slides here? Or?
Yep. Yeah, we see the slides. Everything's good, Dr. Hunt.
All right, great. So yeah, like Shen said, I'm one of the founders and directors of the Pan Image Guided Interventions Lab, which is a big, mostly interventional oncology research lab. But we have broad interest in interventional radiology research, and we'll be talking today about interventional pain management. And so here's my disclosures. A lot of different grant support, both from the NIH as well as the Society of Interventional Radiology and SIR. As well as some industry grants, and then I have, I'm a speaker for Boston Scientific, and I do some consulting in the industry, as well as starting and running some startups. So here's a apropos quote from nearly 2,000 years ago: "The greatest evil is physical pain." That was said by Saint Augustine in AD 400. So when you talk to your patients, they really are the ones who are going to tell you this. I have been, I do a lot of lung tumor ablation and lung tumor management. But I would say that I'm involved in more patient funerals by spouses who are thankful that I got rid of the patient's pain rather than actually killing of their cancer. And so pain from a patient perspective is really foremost on their mind. Almost any kind of medical problem that they get into, what they want to know about is, how much pain is this going to involve, or any procedure that they get involved with, how much pain is going to involve. So pain is obviously central in people's minds. So we're going to talk today about kind of what is pain, how do we measure it, what are some of the causes of it, how do we manage the pain, and then what role do interventional radiologists play in this pain management. We'll talk about some of the tools of the trade in our profession of interventional radiology, and then run through a few case examples. This isn't meant to be exhaustive because the field is quite broad. But just talk about some of the basic procedures, and then a hint at some of the more advanced procedures. So what is pain? Pain is defined as physical suffering or discomfort caused by some illness or injury. Okay, but if you really look at that thesaurus terms there: suffering, agony, affliction, torture, torment. This is what the terms you'll hear from your patients in talking about their pain, and particularly related to cancer pain, but related to osteoarthritis, related to any of the various maladies that beset patients. And when you really look at the root of it, iona from the Latin, this was thought to be penal, punishment. This is a punishment from God, and so this is something that back when the world revolved around the religious interpretation of disease. You think back to the Bible, the first mention of pain was God putting a curse upon Eve, saying that you're going to have pain in childbirth. And so this is the kind of thing that patients really worry about. So how do we measure pain? There's a lot of different site-specific measurements of pain. There's the knee pain score, the Oxford knee pain score. There's all these different pain scores, but really the one that has been tried and true and tested since 1983 when it was published was the Wong-Baker faces pain score. We've all seen it on clinical rotations, the happy faces that go from a smiley face where you have no pain to the crying face where you're 10 out of 10, right? And so just that simple pain rating scale, what's called the PRS, 0 to 10, That really is what you'll see within the literature. It's been heavily validated in pretty much every study, and patients can intuitively understand that. And so usually when a patient is presenting to you with pain, first thing to ask them is, do you keep a pain diary, or do you have some idea about the level of your pain? So you not only want to know where it's coming from and can they localize it, but also, on a scale of 1 to 10, start charting it. And you want them to keep track of that information, because as you go forward, as you're treating them, you'd like to know whether your treatment has been effective. So what causes pain? There's really, broadly speaking, 4 different types of pain. There's nociceptive pain. This is the pain that you think about when you think about pain, and that's activation of, basically some injury to a tissue, whether it be tumor invasion, whether it be trauma, car accident, whether it be something that we do iatrogenically causing a tissue pain, like infarcting fibroids in the setting of a uterine fibroid embolization. Whatever it is, that's basically nerve endings, which are normal nerve endings, are being activated by some pathologic process in the tissue itself. Okay, and these are A fibers, the fast fibers, as if you remember back to your neuroanatomy class, and the C slow fibers. Okay, and that's because the slow fibers are non-myelinated, the fast fibers are myelinated, and that just tells you how fast the signal gets up to the pain. So if you think about when you slam your finger with a hammer, first what you feel is that fast fiber activation. That pain comes, and that very, very intense pain, but it's gone very quickly. And then you have that throbbing. That's your C fiber. That's your throbbing pain. It's much slower to get up there, but it persists for a very long time. And so one thing that you can ask your patients is to describe their pain and get at, is it more of that throbbing pain versus fast pain? And that will give you some idea about what you're dealing with for etiology. Then you have neuropathic pain. Neuropathic pain is actually a direct irritation of the nerve. So you think about, for example, postherpetic neuralgia, right? Shingles that people get after they've gotten, the pain that they get after they've gotten shingles activation, where a virus is running down their intercostal nerves and, breaking out in these skin rashes and things like that. That's an actual direct activation of the nerve, and that's an example of neuropathic pain. But there's also a neuropathic pain that relates to degeneration of the neurons related to diabetes. So there's diabetic neuralgias. So there's a lot of different pains that and knowing that it's neuropathic, it actually tells you what drug class they may respond to as well. Then you have inflammatory pains. You think about rheumatoid arthritis, or the various forms of inflammation that can happen related to tumors, or related to inflammatory bowel disease, or any of these kind of inflammatory etiologies. Those we'll call them immune-mediated pains. And when you think about it, that's cytokines, histamine, prostaglandins. So you can imagine that what's going to stop that kind of pain? Obviously, anti-inflammatory drugs, right? And that's why NSAIDs are really the largest class of drug prescribed in the world. Then you have functional pain. And this is pain that generally we can't find a tissue cause. We can't find a nerve that's specifically damaged, but these patients are having chronic pain syndromes. And so fibromyalgia, there's a number of different chronic pain syndromes, and that probably relates to activation of central pathways in the brain and in the spinal cord that are causing, functionally, the patient is feeling pain. Or if you think about phantom limb pain, there isn't really a limb there or nerves that are having pain, but they've had a pain circuit activated that's activated somewhere upstream in the spinal cord or in the brain, and they're actually having these phantom pains. And so that's kind of the four different causes of pain. And when you think back to neuroanatomy, not to get too deep into it, but again, those A and C fibers, those A delta fibers, which run the signal up, and this is the most youngest, evolutionarily speaking, of the evolution of the pain, and that allows you to very precisely pinpoint where the pain comes from. Those A delta fibers, and they map into actually there's actually 3 different levels of pain perception that evolved over time through evolution. The oldest is this archispinothalamic tract, which projects pretty much immediately to the emotional centers of the brain, the deep limbic structures. And that's the kind of immediate emotional reaction you see babies get where they start crying, and they can't localize their pain. They're not aware of where the pain is coming from. They're just in pain. And this is lower invertebrates and things. They have that same archispinothalamic tract. Then you have the paleospinothalamic tracts that evolved a little bit later. They start projecting forward as well into the frontal cortical structures. And then you have those higher spinal neocortical tracts. And those actually, what's interesting about them is those project up to the cortex, and they also have tremendous amount of inhibitory signals that project back from the cortex down for inhibition of pain. And that's why you can hypnotize someone and literally, remove their hand or do other very painful stimuli to them, but under the profound suppressive activity of their cerebral cortex, which is able to activate pain inhibition pathways. And so much research has been spent on trying to figure out, for example, those pro-inhibitory pathways and how to activate them. I won't talk very much about them today, though. So how do we manage pain? Obviously, the cheapest and the best answer is don't get into pain in the first place. So live a healthy life, eat a healthy diet, get your exercise, try to avoid, overuse of joints and things like that. But then you get, once you start getting some pain, the first things that a doctor will try, and general practitioners generally, is physical therapy to relieve the pain, and then things that are less invasive like acupuncture, things like that. The big bear, of course, in the room is pharma. So when you think about these markets, $1 billion Tylenol market, a $16 billion NSAIDs market. This is things like aspirin and ibuprofen, things like that here in the United States. This pharma market is more than $100 billion a year that we spend on medications for pain. All the way up to opiates, we spend about $12 billion in the United States per year on opiates. You have the GABA analogs like gabapentin and pregabalin, these anti-epileptic drugs that act on neuropathic pain. That's a big market. And then, of course, your biologics that are mostly for inflammation. You then have a little bit more invasive than that is where we stand in this interventional pain market, whether it be interventional radiologists or interventional, anesthesiologists who do interventional pain management. In any case, this is where you're giving, some kind of pain injection like analgesic injections or steroid injections, or you're doing some kind of pharmacologic ablation that we'll talk about using ethanol or phenol, or you're using some kind of thermal energy to directly kill a nerve. And then some other techniques we'll talk about like cementoplasty for stabilization of malignant bones and things like that. Then you get into the even more invasive things like joint replacements for osteoarthritis, decompressive surgeries like laminectomies and laminotomies, tumor resection if it's a tumor that's causing the pain, just taking the tumor out and hoping that you can relieve pain that way, to surgical denervation like rhizotomies, where you go in there with either a needle or laser and you just cut the nerve directly. You have nerve stimulators. So I'm not going to talk a lot about that, but just to see where we are in this pantheon of overall management of pain. Now let's talk just briefly about the opiate market. As you can see here, $12 billion market and growing. Unfortunately, what we saw was this rapid explosion of opiates throughout the 90s. And what you see consequently is this delayed but significant increase in opiate-related deaths, to where it became essentially the #1 cause of death in many demographics over the past 10 years. More than 50,000 deaths per year, and a significant amount of those from prescription opiates. But what happens even more so is that patients get addicted to prescription opiates, and then because they can't afford prescription opiates, it's actually cheaper to get opiates, on the black market like heroin, which is increasingly laced with synthetic fentanyl coming from Mexico, which is made by chemists who are imported from Russia and China and things. And in any case, that's become a huge problem. And you saw these three waves: the 1990s, the early 2010s, and then later of the prescription opioid deaths, followed by street opiates, followed by the synthetic opiates like lacing with fentanyl. And so that's a big problem, and regulators are aware of that. There's been a crackdown on that, and we doctors are in part to blame for this epidemic. And so people are looking for non-opiate answers to pain relief. So tools of the trade in interventional radiology. #1, standard anesthetics, things like lidocaine. But that's really only going to last for a very short period of time. So more commonly, things like Marcaine and bupivacaine. Those are long-acting versions of lidocaine that cause a direct effect on the neuron to basically get a neurolysis. But they wear off after generally 12 to 24 hours. That's their kind of range of effect. So usually we'll put that, for example, into a joint, as we'll talk about, in concert with a steroid, or we'll inject the nerve directly in concert with injecting a steroid, like Kenalog, which is triamcinolone. It's just a synthetic version of of prednisone that we'll inject. Then if we want to actually kill the nerve, if it works effectively for a block, the patient has significant pain relief of doing that procedure, then you can think about getting rid of the nerve entirely with ethanol, absolute ethanol, dehydrated alcohol, or phenol. Both of these are neurolytics that are more permanent. So they cause damage directly to the myelin sheath, and they and to the neuron axon itself. They dehydrate it, and then that pain is not going to come back, or that nerve is not going to grow back for some significant amount of time. Now, obviously, peripheral nerves will regenerate over time, and the length of effect is usually in the 9 months to a year range for these agents. Some additional tools will be things like Lepidol or contrast, which are sometimes mixed with the alcohol or mixed with the anesthetic and steroid, so that you can see where you're at localization-wise. You're going to usually use some kind of thin needle if you're doing a pain injection, like a Chiba needle, often 21 gauge needle. The other thing you can use instead of using ethanol or phenol for ablation of the nerve is you can use a thermoablation technology like cryoablation, which I do a tremendous amount of, radiofrequency ablation, or microwave ablation. So radiofrequency and microwave are just heat-based forms of energy that you're using to directly ablate a nerve or ablate a tumor, as we'll get into. Obviously, what differentiates an interventional radiologist from other doctors who are doing these pain procedures is that we're always using imaging guidance to do the procedure. Whether it be ultrasound, this is an ultrasound of the knee, whether we're looking at essentially the quadriceps musculature, and we're targeting a nerve that might run between this, or fluoroscopic guidance. Here you can see a needle that's placed directly in the infrapatellar space, directly into the joint, and injection of contrast. So you're placing a needle directly into the knee joint. Or here's a version on CT, how it would look of injection of contrast into that suprapatellar space. MRI, exquisite soft tissue detail. Unfortunately, not a lot of tools. Most metals will cause an artifact on MRI, which makes it not feasible, but there are indeed MRI compatible microwave systems and needles for injection. And then some specialty products like bone cements. After you've, for example, treated tumors in the bone or some kind of bone process, you can use a cement to stabilize a bone if that's what's causing pain, and things like kyphoplasty balloons, and we'll get into what that is. So just to run through a few case examples, now that we know what the tools of the trade are, let's talk about osteoarthritis. One of the major causes of pain and disability in the United States. Patients present to their orthopedic surgeon, all they know of is, doc, it hurts, I think I got to get a joint replacement. I work at a veterans facility in 1 day a week, and this is a very common presentation for patients to orthopedic clinic, and then they get referred to us because for many of, in particular, younger vets under the age of 50, the thought is to give them a joint replacement so young, it has a defined half-life, and they're going to end up needing a joint replacement, in 10 to 15 years. And so they try to prolong that native joint as much as possible. So just here are some examples of we do several of these a day in our interventional radiology practice at the VA and other hospitals we work at in the Penn system. So basically, under fluoroscopic guidance, you're placing a thin needle into the joint, and then you inject a small amount of a radio-opaque contrast, like IsoView, into the joint, and that just confirms the positioning of the needle within the joint. So you can see how it spills into the joint there, in the shoulder, or the second image is, of course, of the hip, and so you can see how it kind of spills into that femoroacetabular joint, or into the knee. So in all of those cases, you basically, now you've confirmed placement. So you place that needle into the joint under fluoroscopic or ultrasound guidance. You inject a small amount of contrast. Then you usually inject, we mix our bupivacaine with our steroid, but however you want to do it, you inject 8 to 10 mLs of a long-acting analgesic like bupivacaine into the joint. That's going to provide kind of immediate pain relief to the patient by desensitizing those nerves using basically a long-acting version of lidocaine. You're also then going to inject a steroid, like whether, we use a lot of Kenalog, which is, like I said, triamcinolone, which is a synthetic steroid. but you'll see people use dexamethasone or kind of any steroid. You're injecting that into the joint, and that will generally give a tremendous anti-inflammatory effect and a decrease in the production of inflammatory. And that will provide a longer-term relief, and that's usually lasts in the period of 3 to 8 months. All right. The other things you can do, of course, now that you have access to that joint, is you can inject hyalogen. So for degenerative disease in the knee, that's a very common procedure where you would inject essentially a mixture of collagens that is thought to provide a buffer in the joint. So if a patient has, for example, erosion of their meniscus or bone-on-bone kind of pathology, just having some extra collagen gel in there helps to decrease the pain related to that. Or things like patient-rich plasma, where you basically take the patient's blood out, you spin it down to get the plasma, and then you re-inject that into the joint. So any of those are all variations on the procedure, and kind of the advanced version of that in today's world is use of stem cells to try to repair the damage that's been done. But those are obviously all, for the most part, temporary short-term reliefs of pain for the patient. Eventually the patient will need to go and get a joint replacement. But what about for those patients where a joint replacement is not feasible? Either they're a poor surgical candidate, or they're considered not in the right age range to get a joint replacement, and the physicians don't want to go there yet. Then you can do more permanent versions of ablation of the nerves directly. So when you think about the knee compartment, this is the view from the posterior and the side. You can see the sciatic nerve, coming through, as well as the saphenous nerve anteriorly, and their relationship to the knees and these various articular branches that come around to innervate the knee joint. And for the most part, the nerves that we think about these things in terms of their anatomic locations, are these genicular nerves. So there's a superlateral, a supermedial, and an inferior medial genicular nerves that come around to innervate the knee joint. And those you can target directly, again, just like we did with targeting the joint itself. You can target those nerves, and that's generally just done under fluoroscopy. You can also use ultrasound, and there are ultrasound markers, and you can read the literature on that, where you can actually directly place your needle under ultrasound guidance. But most people are using fluoroscopy for this approach. And so you basically place your little needles in, at the metaphysis of the femur, at the medial and lateral side, and then along the medial side of the tibia, also at essentially the metaphysis. And you're injecting, again, some combination of a neurolytic agent like bupivacaine, as well as a steroid. Now, if that works for the person in terms of, they tell you that they're getting significant pain relief, then what you can do is, instead of placing a Chiba needle, an injection of the nerve blocking agent using that, you can actually place radiofrequency needles. And this is also generally done under fluoroscopy. As you can see, they place them to a specific depth on the lateral, and they know where the neuron is there. And just the tip of the needle there gets heated, and that's enough to cause damage to the nerve, and a significant length of neurolysis, to where the patient is essentially going to have a numbness in that knee. Now, the bad part of that, of course, is going to be, as you can imagine, that pain is there for a reason. Pain is there to tell you that you have pathology, and that perhaps you're walking on the knee incorrectly, or you're overusing the knee. So obviously, the downside of doing any kind of nerve ablation procedure is you're rendering that patient, numb in that distribution, and therefore you can end up with overuse disorders, or you can end up with some motor weakness component. Now, where they place the needles here is to avoid the larger motor components to the knee, but those are generally the risks that you talk about with the patient, in addition to damage to adjacent vessels or muscle. But here you go. Here's a recent article looking at this procedure specifically of RFA, and comparing it to our standard of care, which is corticosteroid injection of the joint itself. And so this is looking at genicular nerve RFA. Again, they targeted those 3 sites that we talked about, which are the superior lateral genicular nerve, the superior medial genicular nerve, the inferior medial genicular nerve. So they targeted those, and they did the ablation. And this was a multi-center prospective randomized trial using that. And what they found in this paper and then in subsequent papers out to 24 months was a significant decrease in their pain score. And again, if you look at this NRS pain score they're talking about, that's just the 10 scale, happy face scale, right? And so patients are starting off at baseline with, on average, a pain score of around 7, and they're decreasing that in the radiofrequency ablation group down to a pain score of about 3, which persists out, if I showed you the follow-up papers, out to 24 months. So for about 2 years, these patients are getting a significant decrease in their pain. It's not completely gone, their knee pain, but they've had a significant reduction in that knee pain that persists out. Whereas if you see what has happened with the intra-articular injection is at 1 month they had a decrease to 4, but by 5 months it's already back up to, by 3 months it's already back up to 5, and by 6 months it's already back up to 6. And so that's what I talk about, that you kind of only have that 3 to 8 month window of effect of the intra-articular injection, and generally that pain is going to recur by a year. And so this was the clinical trial that they ran, so that is now an approved procedure. And this is just their what they call waterfall plot, where you look at percent change, and they set the metric to be you had to have a greater than 50% decrease in your pain score. And most of the patients had this greater than 50% decrease in the pain scores, whereas very few patients at 6 months had a significant decrease, 50% decrease in their pain score using intra-articular injection. So again, not a long-term solution for their chronic knee pain. Let's talk about back pain. So just like you can do with the shoulder or the hip or the knee, you can inject the facet joints, and you can do this under fluoroscopic guidance. That's generally how it's done. And you're basically finding the facet. As you can see, it's along that superior aspect of the end plate, just lateral and out there at the transverse process. You're targeting that. You're placing your needle. You're injecting. You'll see it smear up the facet itself, up the joint, and you're in the right place. And then you deliver your bupivacaine or other neurolytic agent, as well as your steroid. So very, very common procedure. You can also do this with more, exquisite control and visualization under CT guidance. But obviously you'd have to have a CT scanner, and that has additional cost. And there's just some references for if you wanted to read more about those techniques specifically. But let's talk about even more advanced procedures, like what happens if you have a spinal fracture? Can we do anything about that? So osteoporotic fractures, as our patients are living longer and longer, we're seeing more and more of this, and as patients are unfortunately more sedentary, this is also an issue. And so osteoporotic fractures are quite, common. And what you can do is place a needle, basically drill in through the posterior facets, as you can see in the front of this, the first image here, and either just inject cement, bone cement, and that's called a vertebroplasty, or as the technique has evolved, more effective it's been shown is to actually try to increase that vertebral body height, because you can imagine that if you just inject cement, whatever nerve is getting pinched and causing pain is not going to be relieved by that. It can help to stabilize it and make it not get any worse, but it's not going to actually relieve the pain. So by inflating a balloon in the vertebral body, what you'll do is you'll actually increase again the space within those neuroforamina and relieve the pinching of that nerve. And so you inflate the balloon, then after you inflate the balloon, you've basically created a space there. Now you fill it with cement, and then you withdraw your needle and things like that. And essentially you can see what that actually looks like as you're doing it under fluoroscopic guidance. You can also do this under CT guidance. But in any case, you basically drill into the through those posterior pedicles and into the vertebral body. You place your balloon through. You basically blow up the bone again using that balloon. So it's obviously quite high pressure balloon, and then you're filling that space with cement, and that's stabilizing and increasing the those neuroforaminal spaces. And then we've all seen patients, if you're on clinics where you can see the cement within those spinal bodies on X-rays. What about if a patient has not osteoporotic fractures, but cortical erosion of bone that relates to tumor? So this is a very common problem. Anybody who treats cancer patients knows that this is kind of one of the #1 causes of pain in our cancer patients is bone metastases. And the reason why is because while the marrow is not really innervated per se, it's that lining, that periosteum that lines the bone and coats it, that is exquisitely sensitive. And so as the tumor grows out of the marrow and into that periosteum, it causes a tremendous amount of pain to the patient. So what you want to do is obviously stop. It's where the tumor meets the bone that is most painful. It's that tumor bone interface. And you want to stop the growth of the tumor. And at the same time, of course, you're going to create a cavity by just killing the tumor. So what we do is we put a needle, drill a trocar, which is a larger needle in, take out the center of it. And so it's a kind of hollow trocar. And then through that, put another needle that contains a cryoablation needle, or it contains a radiofrequency ablation or microwave. And what you do is you treat the tumor with that to kill it. And then what you do is you withdraw that and you inject through your trocar this cement, and that stabilizes it. And so there's an example there of a painful spine metastasis that has been ablated using a microwave and then cemented in place. But just like you can do it in the spine, you can do that in any bone. I do it most commonly in the pelvis, because in lung cancer, it's very common to get painful metastases in the pelvis, also in prostate cancer. And so you can both treat the tumor directly as well as stabilizing that bone so that they're at less risk of going on and getting pathological fractures. Also, if they have pathological fractures, use of that cement can help to stabilize those bone-bone interfaces where those pathological fractures are so that they're not as painful for the patients. And so this is an example. You can see that we can do it under fluoro, we can do it under CT guidance. This is a femoral metastasis that's being treated with microwave ablation and cementoplasty. Okay, and then let's get into visceral pain. Okay, so bottom right. So visceral pain is very often, it can be caused by a number of different things, very commonly malignancy, pancreatic cancer, or lymphoma or other retroperitoneal cancers, or peritoneal carcinomatosis in the setting of a lot of gynecologic malignancies. And so all those things basically are invading the lining of the belly, right? Peritoneum. So how are you going to treat this very diffuse, painful process? And what patients will tell you is that their whole belly hurts, it aches, and they get twinges of sharp pain, but for the most part, it's just this very chronic, unrelenting, visceral pain. Okay, and what that is due to is usually the splanchnic nerves, which are for the most part contained. They exit the spinal cord and they all coalesce in the celiac plexus around the celiac artery and the superior mesenteric artery. So that area between and around the celiac artery and SMA is where you want to target for the plexus. But in addition to that, you can target the sympathetic trunk itself by going retrocrural. So you can see that in this diagram, a needle is being placed both retrocrural to hit those splanchnic nerves that are coming off the spine directly, and that will also, they run kind of superior inferiorly down in that retrocrural space and behind the diaphragm, and they kind of go to different levels. But most of them will go synapse through the celiac ganglia, which is just anterior to the aorta. So you can place needles in both of those locations, retrocrural and anterocrural. You can imagine that you can do that. Most commonly, I do it from a posterior approach in CT, but you can also do it as being shown here in this picture, an anterior approach. And you're basically targeting what you can see in this picture here is, sorry, just looking for my arrow. What you can see here is the SMA coming off here, and they're targeting the nerves there, the neural plexus around the SMA. And so you can imagine they can go behind the diaphragm, so retrocrural, and get those splanchnic nerves directly, as well as anterocrural. And I usually try to have, I'll treat both anterocrural as well as pull back and treat behind the diaphragm as well to make sure that I'm covering the nerve roots as well as the ganglia. And so you inject a little contrast to confirm your localization, and then you inject your bupivacaine or your neurolytic agent, which is going to directly, allow pain relief. After about 15 minutes, you can usually ask the patient, is your belly pain getting better? If they are reporting that it's getting better, either you can just do a big bupivacaine block and give it a few days and make sure that it works before bringing it back for a second procedure, or more commonly, I think, is to give it, 15, 20 minutes. Yes, the pain is improving. Then you can directly inject through the same needle position your ethanol, absolute ethanol or phenol, and that's going to directly cause damage to the nerve and what's called, a more permanent neurolysis. You're actually going to try to kill those nerve roots and destroy that celiac plexus. Now, what can you expect that you're going to get? Well, the patient can get digestive, problems related to essentially less propulsion of food through the gut, so they can get kind of an ileus kind of syndrome. Usually that's short-lived, and it generally is not significant for the patient. Obviously, if you inject the ethanol in the wrong place, if you injected it into the aorta, that could cause serious problems because it could go up the superior mesenteric artery and cause bowel infarction, or it could go into different places. So it's very critical that you get it basically into the right place and not into the wrong place. But I use ethanol. Some other people use phenol. I think ethanol is most common. You could do the same kind of procedure though using a cryoablation needle, where you could put that in, from a posterior approach right alongside the aorta and ablate the nerves that way. Let's talk about pelvic pain. Most of the pelvic pain neurons are coming from the superior and inferior hypogastric plexi, and those run along the sacrum, the largest of which is that superior hypogastric plexus. So where you will see this a lot used in interventional radiology, in addition to things like endometriosis and chronic pelvic pain syndromes, is you'll see it used a lot as a temporary, just as a blocking, not as a neurolysis, but as a blocking procedure in patients who are going to get uterine fibroid embolization. So when patients come in and they're going to come into, for example, an outpatient laboratory or an outpatient IR facility where they're going to get treated and they're not going to get sedation, or they're going to get minimal sedation because they're trying to allow the patient to come in and leave the same day and have significant pain relief that's covering them, overnight, is that they'll target the superior hypogastric plexus, and you can see that the superior hypogastric plexus kind of usually sits just below the L5-S1 disc space. So if you're looking anteriorly at the patient's pelvis under fluoroscopy when you're getting ready to do your uterine fibroid embolization, you basically literally poke straight down through whatever you go through, the uterus and the bowel and whatever. You get down to the level of the disc space itself, and then you back it up a little bit, and you're injecting your bupivacaine in that spot. And that generally, again, will last about 18 hours and provide significant pain relief. And at that point, the patient is at home and they're going to be taking hydros, Motrin and anti-inflammatories to help with their pain from their embolization procedure. All right. So in review, we covered, kind of an overview of what is pain for the patients, as well as, what is causing it from a neurologic perspective. How do we, the most common pain measurement scale, and how we manage pain, what role we play as interventional radiologists and image-guided therapists in addressing pain in our patients. Some of the tools for the trade, including the neurolytic agents that are used for temporary pain relief, as well as the more permanent ones like alcohol and phenol, as well as things like thermoablation, like cryoablation, radiofrequency ablation, and microwave ablation. We talked about some of the more advanced techniques like cementoplasty and kyphoplasty for treating fractures in the spine, and just generally talked about some case examples. Obviously, there's a whole world out there of anywhere there's a nerve, you can imagine there's a way to target that nerve with a pain procedure. So I do a lot of intercostal nerve blocks and then ethanol ablation of the intercostal nerves for patients with post-thoracotomy pain, because I work a lot with thoracic surgeons who are treating lung cancer, and so they know me because they refer me a lot of patients for lung ablation. But also I do a lot of their post-surgical problems like thoracic pain after surgery, post-thoracotomy pain. But also you can imagine the shingles population, all those folks also come in with these post-herpetic neuralgias, and in fact I have one tomorrow that I'll be treating for that. So that's a very common procedure. You can imagine there's a lot within the head and neck, and a lot of those pain procedures are often done by interventional neuro folks, so the neurointerventional radiologists, as well as by specialized neurosurgeons who learn these kind of techniques. So just I hope you had you feel like you got a flavor for some of the tools, some of the techniques that we do. You can imagine they can be applied in different places. And any questions, I'm open to it. This is just my lab, some of the folks from my lab. Yeah, thanks so much, and open for any questions.
Thanks for the lecture. We have a question from the audience, I think from Varun Danda. The question was, what are your thoughts on genicular artery embolization to reduce pain in the patient with knee osteoarthritis?
So yeah, so I almost included that one. I didn't want to get into embolization too much. I think that what I would like for that procedure is to have the same level of clinical evidence kind of as the RFA, which is that you run a randomized controlled clinical trials demonstrated. I do think that we have a lot of retrospective series in that space. There's a number of patients who have been treated and some very large series looking at that, but we really need that randomized controlled trial. And that's a difficult thing to do, as you can imagine, to randomize people to sham procedures like placement of a catheter all the way into the various geniculate arteries and injection of saline versus embolization. But that's the kind of thing if we really want to get uptake of that procedure, we need that level of evidence so that the payers like Medicaid and things like that will cover that. But I think it is a very promising technology. It's obviously not targeting the neurons directly like the RFA. It's targeting the inflammatory component within degenerative disease in the knee. And so whether it's going to work mostly for the inflammatory arthritides versus for osteoarthritis is another open question that I think will need to be addressed.
Thanks very much. Anyone else have the questions? You can type in the question box here. I guess in the meantime, I have a general question, which is, I think a lot of interventional radiologists, pain management is not, I guess part of their routine practice. So I guess how do you get into, I suppose, pain management in the first place, and how do you, approach about getting patients and then getting referral like that?
Yeah, well, like I said, pain is a greater than $100 billion worldwide industry, and so there's no shortage of patients who are in pain. Really, what it's a matter of is that your referring physician colleagues know that you're capable of doing those procedures. So in my case, because I'm always an active participant at the lung cancer tumor board every week, it's a multidisciplinary tumor board that consists of surgeons and medical oncologists and radiation oncologists and interventional oncologists, me, as well as the palliative medicine folks. And so very quickly, what happened to me in my practice now, 6 years ago or so, was the palliative care folks who were often at those thoracic tumor boards realized that I had tools that I could offer and treatments that I could offer for their patients in pain. And so they started sending me patients for, celiac neurolysis, for example, because they had lung cancer that had metastasized to their belly somewhere and they had intractable pain. Or the thoracic surgeons realized, oh, you can treat post-thoracotomy pain, because they would just casually mention, oh, this poor guy, I've resected him, but now he's just got this chronic chest wall pain and I can't do anything about it. And so I said, hey, I could do it, intercostal neurolysis. So I think a lot of it is educating your referral physicians about the techniques that you're able to offer. And then I think giving talks, I'll post sometimes pictures of procedures, anonymized procedures on Twitter or on Instagram and other social media platforms. And so patients self-refer. So I have had a lot of patient self-referrals where they're like, hey, I've been living with this pain forever. Obviously, within the VA system, the orthopedic surgeons know that we do these joint injections. So they send us a lot of patients for this because they're trying to prolong the native joint as long as possible. But I think that part of it is you put together a talk like this, tailor it, for example, for your orthopedic colleagues, and you say, hey, I can do these facet injections, I can do these joint injections. This is the data of how long they last. I can do, in this case, geniculate RFA, which seems to provide a 2-year benefit versus intra-articular injection for chronic knee pain. So you put together kind of a review of the literature and such a thing, and then you go ahead and set up a time with your referral base, and you talk to those docs about, you know, the various procedures you're able to do. So any interventional radiologist could get into this space. It's really a matter of educating those referral docs as to what you have to offer. And any additional questions that folks have, obviously you can email me directly at my pen, you know, just my name, stephen.hun@penmedicine.upenn.edu, and happy to, you know, answer anything specific.
There's one last question, I think, from Nathan Kaufman. The question is any interest in using irreversible electroporation for precarious nerve ablation regions? I guess in the case, for example, I guess celiac plex nerve blocks or neurolysis. Is there any interest in using that?
So I think that IRE has been used for some nerve ablations. The issue with it, of course, is that it's quite stimulating the nerves. And so generally it would require the same as anytime you use IRE, it's going to require general anesthesia. So my only thought would be that probably those are patients where you've already done a block and demonstrated with the block that patient benefited from the block, because when you get the patient in for the procedure, they're going to be essentially asleep and they're not going to be able to give you any feedback as to whether a block works. So I think that most commonly that's going to be patients where you've done a block, you know that has provided the patient relief, and then you're going to go back with general anesthesia and do the irreversible electroporation.
I think that's the last question from the audience tonight. If there's no more further questions, I think we're just going to conclude here. Well, thanks for everybody for showing up for the webinar tonight, and then thanks Dr. Hunt for giving the webinar. That's very.
And this webinar will be posted to the SIR.
Yeah, we'll get it up.
YouTube channel. Or?
Yes.
It'll be on YouTube also.
Okay, so there you go. So share with your colleagues.
All right, will do. All right, thanks a lot.
Thank you so much.